Everyone. In this video, we'll be discussing about clozapine in detail. As we know that clozapine is one of the most important drug in psychiatry, and it is the only drug, actually it is the only FDA approved antipsychotic for reducing recurrent suicidal behavior in schizophrenia and schizoaffective disorder. At the same time, clozapine is also considered a gold standard treatment for treatment resistant schizophrenia. So what is important about clozapine is two important things we should remember that clozapine is the gold standard treatment for treatment resistant schizophrenia, and second is it is the only antipsychotic. It is the only antipsychotic which is FDA approved for reducing suicidal behavior in schizophrenia and schizoaffective disorder. Okay, reducing recurrent suicidal behavior in schizophrenia and schizoaffective disorder. Okay, this is clear. Schizoaffective disorder. This is clear, my friends. So, but we need to remember that clozapine is also one of the most frequently and carefully monitored drug in psychiatry because it has very severe side effect, which we'll be studying in the detail. And so, to understand clozapine properly, we must understand actually both the part of the clozapine. One is why clozapine is so effective, and at the same time, why clozapine is so risky and requires very strict monitoring. So in this lecture, we will be actually covering about the classification, mechanism of action, the receptor profile of clozapine, FDA approved and off-label indication, along with that pharmacokinetics and pharmacodynamics, what is the dosing regimen, what is the target dose, its side effect, black box warning. In this lecture, we'll be taking the standard sources like Kaplan and Sedok CTP, okay, Kaplan and Sedok CTP, Tasman, Tolp, and Carlet. Okay, and some data will be also taken for Oxford textbook of psychiatry. Okay, so whatever we will be discussing here will be all from the standard sources. Okay, so starting with that, what is more important is first we'll be starting with the classification of the clozapine. So classification of clozapine, as we know, clozapine is a second generation antipsychotic, and it is a prototypical second generation antipsychotic, and it is a prototypical atypical antipsychotic. Okay, clear? Sometimes also act as a mood stabilizer. Also means in treatment resistant bipolar disorder, we also give clozapine as a mood stabilizer. Okay, so this was a traditional classification. However, under the new classification, that is neuroscience based nomenclature, that is a NBN classification, it is classified as dopamine, serotonin, norepinephrine receptor antagonist. So what it is under NBN classification, it is classified as dopamine, serotonin, norepinephrine receptor antagonist. Okay, AN stands for antagonist. Okay, so more specifically, if we talk about here, it acts as a more specifically, if you need to remember, it act as an antagonist at D2 receptor, 5-HT2 receptor, and norepinephrine on alpha 2 receptor. Okay, on alpha 2 and alpha 1 receptor. Clear? So now from this we clearly remember, and we can see that it is having a multi-receptor profile. Okay, and now we will be discussing why clozapine is unique. So clozapine is unique because of its it has a powerful antipsychotic efficacy. At the same time, it is having low extrapyramidal symptom risk. One important property is that it is having anti-suicidal efficacy, and it's an antipsychotic which has shown a possible benefit in negative as well as cognitive symptoms. The reason why it is useful in cognitive and the negative symptoms we'll be discussing in detail at the receptor level. Along with that, it has shown efficacy in treatment-resistant schizophrenia, severe aggression, and hostility. And an important thing you should remember that it has an off-label indication of clozapine is that it is efficient in psychosis at a dose of around 25 mg to 75 mg in Parkinson disease psychosis. Okay, but so much of good things in clozapine is present, but at the same time, it comes with a cost that is a complex side effect profile. So clozapine is a drug which is having a high benefit as well as it requires a high monitoring. Okay. So coming to the core mechanism of clozapine. Coming to core mechanism of clozapine. See, in psychopharmacology, it is very easy to remember about the mechanism as well as the side effect if you go at the receptor level and study in detail. Once you study in detail, it will be very easy for you to remember any of the drug and any of the FDA approved indication and any of the side effect. There's no need to mug up. But the most important thing is that you should keep reading the standard textbook and not always go behind articles or everything. You have time for reading articles, but you should first read your basic textbook, that is synopsis and called essential psychopharmacology. These are the two main books you should read. So the core mechanism of the clozapine can be summarized as under: it is a antagonist at first thing is it is a weak dopamine D2 receptor antagonist. Second thing is important that it is a strong, okay, strong serotonin 5-HT2A receptor antagonist. Okay. Third important thing to remember here, the core mechanism is that it shows a fast dissociation from the D2 receptor. How it is useful in the clinical profile of the clozapine, we'll be discussing later why fast dissociation is important. And at the same time, it is a strong antagonist action at histaminergic receptor, that is H1 receptor, alpha 1 and alpha 2 receptor, as well as the muscarinic receptors, as well as the muscarinic receptors, as well as at the serotonergic receptors. Okay, this much is clear. Now, coming to one by one, we'll be discussing the receptor profile in that detail, and then we'll be going forward. Okay, so first we'll be taking dopamine D2 receptor profile. I'll be explaining you and be writing in point voice, so it will be easy for you to make your own notes and study. So clozapine is as we studied earlier, it is a weak B2 receptor antagonist. Okay. So at the clinically effective dose, the target dose we will be learning in the later part. Okay. So it's a weak D2 receptor antagonist, and the clinically effective dose, it occupies only 40 to 50% of the D2 receptors. Okay, it occupies only 40 to 50% of the charted D2 receptor, which is actually much lower than the typical antipsychotics. Okay, so what we know that typical antipsychotic commonly produce antipsychotic action when the occupancy is often around 60 to 80%. Okay, commonly produce antipsychotic effect at around 60 to 80%. But what is important in clozapine, that it even shows the antipsychotic effect at 40 to 50% of the occupancy. Okay, so why here the important thing to know is, since that a typical antipsychotic commonly shows an antipsychotic effect in 60 to 80%, and when the occupancy increases greater than 80%, extrapyramidal symptoms risk increases like Parkinsonism, dystonia, akathisia, and other extrapyramidal symptoms. Here, clozapine becomes different. Okay, so because it due to if occupancy is relatively low, so it produces an antipsychotic benefit while having much lower EPS liability. Okay, the second important thing to remember here is, in case of D2 receptor antagonism, that shows fast dissociation from D2 receptors. Shows fast dissociation from D2 receptor. Okay, so this is another important mechanism, that is fast dissociation. What happens that clozapine binds loosely to D2 receptor. Okay, what is here very fascinating fact is that it binds more loosely than dopamine itself. So what is the usefulness here? What is the impact of this? The impact is this, that clozapine attaches to D2 receptor. Okay, it attaches to D2 receptors. Okay, it dissociates rapidly. Once it dissociates rapidly, what happens? D2 receptors are again exposed. Okay, so there is no rigid D2 blockade and no rigid D2 blockade. Okay, and no sustained blockade will be there. If there is no sustained blockade, what advantage we will have it? So the advantage will be whatever small amount of endogenous dopamine will be present, it will be still producing transient physiological transmission. Okay, and how it will be here, this will be useful. So this transient D2 blockade permits the near normal dopamine transmission. So this actually helps to protect against EPS. Understood? So there will be no rigid D2 blockade and no sustained blockade, and the normal endogenous dopamine can still produce transient physiological transmission. Okay, and this help to protect against EPS. This help to protect against EPS. Clear? So clozapine has two protective mechanism against the motor side effect. What are these two? First one is low D2 receptor occupancy, and the second is fast D2 dissociation. Okay, so you can write this down. That is two protective mechanism, two protective mechanism against motor side effect are, first is low D2 receptor occupancy, and the second one is fast D2 dissociation. Clear? This is all about the D2 receptors. Now coming to the third mechanism, which is very important, is the serotonin 5-HT2A receptor antagonism. Okay. So in contrast to the weak D2 receptor blockade, so what we see that clozapine has a potent antagonist effect, affinity for the serotonin 5-HT2A receptors. Okay. So clozapine has a strong affinity for 5-HT2A receptors. Okay. So once a strong affinity for 5-HT2A receptor. So this is also a key part of the atypical antipsychotic profile. Okay. Through 5-HT2A receptor antagonism, it actually also decreases the EPS. It actually reduces the EPS also, and it also allows improvement in the positive symptoms of psychosis. How? See, this combination of, see, I'll be telling you the facts, and then I'll be telling you the concept, and then we will be writing it down, so it will be become easy for you to understand. Okay, so this combination of what? First, uh, weak D2 blockade, and second one, strong 5-HT2A blockade. Okay, so this actually enhance dopamine release in certain brain regions. Okay, so it enhance dopamine in certain brain regions. So what is useful here is that because of this, we get two important effects. First, decrease extrapyramidal symptoms, and the second one is improvement in positive symptoms of psychosis. Okay. The 5-HT2A antagonism is also responsible for decreasing the dopamine level in the mesolimbic area, which is actually responsible for the psychosis. And at the same time, it increases dopamine in the mesocortical level. Okay, and in the mesocortical. From there, it is useful in actually improving the cognitive function in case of patient with psychosis. Okay, coming to the dopamine release and the EPS reduction. Okay, so what we have seen, we have already seen that the strong 5-HT2A blockade promotes the dopamine release in the specific regions, because of which there is actually reduction in the EPS. Okay, so coming to the fourth mechanism, that is dopamine D4 receptor affinity. Dopamine D4 receptor affinity. So it is seen that clozapine shows tenfold affinity for D4 receptor compared to another other antipsychotics. Compared to other antipsychotics. So, and we see that dopamine receptors are D4, dopamine D4 receptors are actually prominent in the cortical regions of the brain. Cortical regions of brain rather than in striatum. Okay. But actually, even it has been shown that the clinical efficacy of the D2 receptor is still not known. So, just for the fact sake, I'm telling that it has a tenfold affinity for D4 receptor as compared to other antipsychotics. Okay, so clinical relevance of D4 is still unknown. Okay. Now, after the antipsychotic profile, which is mainly due to D2 receptor and 5-HT2A receptor antagonism, coming to the other receptor actions. Coming to other receptor action. Okay, so in the other receptor action, we'll be discussing each receptor at time and what are its implications. First is it shows an antagonist activity at H1 receptors. So, friends, what happens by H1 receptor antagonism? Sedation, important point. Second is increase in the appetite. Third is weight gain. Okay, clear? The second one is it also acts as a antagonist at 5-HT2C receptor. 5-HT2C receptor antagonist. What does 5-HT2C receptor antagonism do? First is the it increases the cognitive efficacy. So it has mood related benefits. Okay. It improves the cognitive symptoms of schizophrenia. Okay. Clear. But comes at a cost. The cost is it is responsible for the weight gain and metabolic burden. Metabolic burden. Okay. So because of these two receptors, it is important to know that clozapine has a very high metabolic burden, and because of this, weight gain is significant. Okay, weight gain is significant in case of clozapine. Clear? Now coming to the other receptor action, uh, other receptor is alpha 1 receptor antagonist. What happens by alpha 1 receptor antagonism? First important thing is orthostatic hypotension. Orthostatic hypotension. Second important thing is due to orthostatic hypotension, what can happen? Patient can feel dizziness because of the that. Again, because of the low BP, what patient can have syncope. Okay, and sometimes when there is a rapid titration, patient could also enter a cardiovascular collapse. Cardiovascular collapse. Okay, especially during rapid titration. Clear? So, because of all this reason, it is very important that you should titrate the clozapine very slowly. And this is actually the reason why clozapine is started very slowly. Clozapine started very slowly. Clear? Now coming to the alpha 2 adrenergic blockade. Coming to fourth, that is alpha 2 blockade. What does alpha 2 blockade causes? Okay. Alpha 2 blockade may contribute to the clozapine autonomic effect and also to the sialuria. Okay. That is increased salivation. It could contribute to sialuria. Okay. And second one, autonomic effects. Like decrease in the BP also, it's contributed by this also. Okay. Now the fifth important receptor on which clozapine act is, this is actually important, that is it act as a partial agonist. Okay, it acts as a partial agonist. Till now, we were actually studying about all about the antagonism. Antagonist at D2, antagonist at 5-HT2A, antagonist at 5-HT2C, H1, alpha 1, alpha 2. Now here comes the first agonist action of the clozapine, which is partial agonism. It acts as a partial agonist at 5-HT1A. And what do we see? Always remember that partial agonist action at 5-HT1A is responsible for what? Anxiolytic action. It is responsible for anxiolytic action. Which other drug causes actually, it's a partial agonist at 5-HT1A and causes anxiolytic action? Anyone knows? Buspirone. Okay, clear? So by being partial agonist at 5-HT1A, it is responsible for mood stabilization. Clear? It is responsible for mood stabilization, possible cognitive benefits. And the important thing is it is also having an anxiolytic effect. Anxiolytic effect. This much is clear. So this was at the receptor level we were talking about. Now coming to the important, one of the important concept in of the clozapine is its active metabolite. This is very important. Listen to very carefully. One of the active metabolite of clozapine. So what happened? That clozapine, once it goes inside the body, it gets converted into NDMC. What is NDMC? N desmethyl clozapine. N desmethyl clozapine. Okay. So NDMC actually accounts for approximately 40 to 80% of the clozapine concentration. It accounts for approximately 40 to 80% of clozapine's concentration. And you know what? Actually, the pharmacological profile of NDMC is actually a bit different from that of the clozapine. Okay, so the clozapine clinical effect is not only due to the clozapine itself, but also due to the NDMC. Okay, so the actually clinical effect of clozapine, if we see, is due to both. First, the parent drug, that is clozapine, and second one, that is NDMC, that is N-desmethyl clozapine. Now coming to the important part, what is the NDMC receptor profile? This is very important. NDMC receptor profile. This you need to remember because it will be very useful for your understanding. Okay. So it has agonist action at two receptor and partial agonist action at two receptors. Okay. You can remember like this, that it is a agonist at two receptors and it is a partial agonist at two receptors. So where it is agonist? Can anyone tell? It is M1 receptor, that is muscarinic type 1 receptor, and the second one is delta opioid receptor. Okay, and it is a partial agonist at which receptor? D2 receptor and D3 receptor. So this is actually important, and this is different from the parent compound. The parent compound was showing antagonist action at around 4 to 5 receptor and partial agonist action at 5-HT1A, while N-desmethylclozapine shows an agonist action at M1 receptor and delta opioid receptor and partial agonism at D2 and the D3 receptor. Thus, we see what is the difference here. If we consider about the M1 receptor profile, if we see about the M1 receptor profile, it is important that clozapine act as an antagonist. Clozapine act as an antagonist and NDMC act as an agonist at M1 receptor. Now you will be asking me, sir, suppose clozapine is an M1 receptor antagonist and NDMC is an agonist. So which effect will actually dominate? So as we studied earlier, from here you can see clearly that clozapine actually get metabolized to NDMC and NDMC forms around 40 to 80% of the clozapine concentration. Okay, since 40 to 80% of the clozapine concentration is NDMC, so it is very clear that the action of the NDMC will be predominant as compared to clozapine in case of M1 receptor. So what will be the predominant action at the M1 receptor? The agonist action. And because of that agonist action, it improves the cognitive profile. Okay, clear? So now we'll be discussing about the NDMC action. NDMC action, that is M1 agonism, and at the same time it causes NMDA modulation. So this is very important for you to remember because it is sometimes asked also what happens. NDMC, what does NDMC do? NDMC is assume that NDMC potentiate NMDA glutamatergic currents or actions. Okay, it potentiate the NMDA glutamatergic currents, and NMDA stand for N-methyl D-aspartate. Okay, Okay, it actually potentiate the NMDA actions. Where it potentiate? It mainly potentiate in the hippocampus. This is important. It potentiates in the hippocampus. And what does it do? Suppose if it is potentiating the M1 NMDA action, and what is actually potentiating the NMDA action? This M1 agonism. The M1 agonism action of the NDMC potentiate the NMDA actions. Okay, and NMDC M1 agonism potentiate the NMDA action, especially in the hippocampus. And what does it do? This potentiation as well as the M1 agonism, it improves two things. What it will be improving? First, negative symptoms of schizophrenia, negative symptoms of schizophrenia, and the second will be cognitive symptoms of schizophrenia. So this is one of the mechanism why clozapine may be superior to other antipsychotic in treatment-resistant and complex schizophrenia cases. And it is seen that wherever there is a higher plasma ratio, there is a higher plasma ratio of NDMC to clozapine. Okay, it has shown better clinical outcome. This is clear. So NDMC is not just a byproduct of metabolism, and it actually contribute to the clozapine therapeutic superiority. Okay, this much is clear. Now, this was all about the action of the receptor and its the metabolite. Coming to the FDA approved indication. FDA approved indication. So there are only two FDA approved indication of clozapine which you need to remember. First one is treatment resistant schizophrenia. Okay, what is treatment resistant schizophrenia? It is this will be dealt. I'll be dealing in another lecture in detail. But for time being, a summary of the treatment resistant schizophrenia. It is defined as failure to respond adequately to at least two other antipsychotic trial, of which at least one should be second generation antipsychotic, and which should be given for an adequate duration and an adequate dose. Okay, and the second important indication is reduction of recurrent suicidal behavior in patients with schizophrenia and schizoaffective disorder. So this is very important. Okay, this is very important. Why? So clozapine is not only an antipsychotic; it has a specific anti-suicidal indication in schizophrenia spectrum illness. And which study? It is sometimes asked in the exam that which study was actually responsible for showing this. That schizophrenia is responsible for reduction in the suicidal behavior in schizophrenia spectrum. The name of the study is, it is very important to remember, the intercept study. The intercept study. Okay, do remember this. This is all given in Kaplan and Sodoc CTP. If you go and read in detail, it's very given beautifully. Okay, clear. Coming to the off-label use, off label use. See, I'll be writing just the points and I'll be explaining how it will be effective in the off label use. The first off label use is treatment resistant bipolar disorder. Okay, when it will be considered, when other mood stabilizer and antipsychotic will be failed, then only. Second will be severe treatment resistant depression. Okay, third one will be violent or aggressive behavior, violent or aggressive behavior. So clozapine is actually used for violent, aggressive behavior, hostility. Okay. Coming to the fourth is, that is Parkinson disease psychosis. Why can't we give other antipsychotic in Parkinson disease? because other antipsychotic have a liability to cause EPS. So actually, it will be worsening the Parkinson symptoms. Okay, but since clozapine has a low EPS liability, it can manage the psychosis without worsening the Parkinsonism. So at what dose it actually we give effective dose? The effective dose in Parkinson disease psychosis we studied earlier in this lecture, it was 25 to 75 mg per day. Clear, my friends? Okay. This was the fourth action off label. Coming to fifth, the fifth one is tardive dyskinesia. Tardive dyskinesia. Okay. Why it is useful in tardive dyskinesia? Again, the important property of clozapine that it does not worsen the EPS, so it may help to suppress the abnormal movement. Sixth one is essential tremor sometime. However, it is off label and comes very behind in the treatment. The main treatment of essential tremor is, that is propranolol and primidone. Coming to the Huntington disease. Okay. Yeah. So there are total seven off-label uses. First is TRBD. Second one is treatment-resistant depression. Third one is violent or aggressive behavior. Fourth one is Parkinson disease psychosis. Fifth is tardive dyskinesia. Sixth is essential tremor. And seventh is Huntington disease. Okay. So this is revised. FDA two indication are there. First one is treatment-resistant schizophrenia, and second is recurrent suicidal ideation in case of schizophrenia spectrum disorder. Okay. Now, what we will be doing now? Well, now we will be going into the pharmacokinetics. See, this is important pharmacokinetics for any drug because once you know the pharmacokinetics, it becomes very easy for you to uh, tell the dosing, how to dose, how to titrate, and what is the interaction between the drugs. So it becomes very easy for you. So currently in India, clozapine is available in only oral form. Okay, oral form. So what is important here? It reaches a peak plasma concentration. Peak plasma concentration in 2 hours after dosing. Okay, this has been taken from Kaplan and Sodok. You can go there. And also, it is very important that it has a high volume of distribution. It has a high volume of distribution. What does it means? What do you understand by high volume of distribution? It mainly means high volume of distribution. It means that there is extensive distribution into the body tissues. See, if you want to remember, you can remember the numbers, but it is not actually not useful for you to remember. It's just 2 to 5.1 liter per kg. I'll be writing it, but it's actually non-significant for you to remember for the exam purpose. So if you want to remember the fact, you can, but not good, not actually not useful. Okay. Coming to the first pass metabolism and bioavailability. Coming to the So this is getting covered under pharmacokinetics only. Okay. The second part is the first one was absorption. Okay. Absorption and distribution. Clear? Coming to the first pass metabolism and bioavailability. We studied about it a bit when we were discussing about NDMC bioavailability. Okay. So what is the first pass metabolism of clozapine? It goes an extensive first pass metabolism. Extensive first pass metabolism. So what do you understand by this, that extensive first pass metabolism? So it is very important to know that where it is occurring first. Extensive first pass metabolism occurs in the liver, and the second it occurs in the gut. So what do you understand by this? Whenever there will be a liver disorder, okay, suppose there is a liver failure, there is a mild, moderate, or a severe liver disorder. In that case, you need to decrease the dose of clozapine. Why? If the clozapine will not be metabolized, what will happen? It will lead to accumulation of clozapine in the body, which could lead to clozapine toxicity. Okay. So from this is clear. And because of the extensive first metabolism, what happens? Its oral bioavailability. Its oral bioavailability is only how much? 27 to 47%. Okay, given in CTP, you can go and read from there. Okay, so even though it is taken orally, only a significant fraction is metabolized before reaching the systemic circulation. Okay, understood? Now coming to the third part of the pharmacokinetics, that is metabolism and excretion. Okay, so it is what we studied, extensively metabolized by the liver. Okay, since it is extensively metabolized by the liver, where the metabolism occurs, it occurs in the cytochrome P450 system. Okay, and the most important enzyme which is responsible is, you all know this, CYP1A2. CYP1A, clear? And the other minor contribution come from, other minor contribution come from CYP2D6, CYP3A4, CYP2C19. So if you will be asking me, sir, which one to remember, the most important is CYP1A2, because when we will be studying about the interaction with the other agents, CYP1A2 will be coming into actions. So approximately 80% of the, this we studied about the metabolism. Now coming to the excretion part, that approximately 80% of the administered dose is excreted in urine, okay, and feces as metabolite. Okay. So around 80% of the administered dose is excreted as metabolite in urine and feces, and less than 5% is excreted unchanged. Okay. So clozapine is mainly cleared by the metabolism rather than unchanged renal excretion. Okay, this is clear. Coming to the half life. Okay, coming to half-life. So the average elimination half-life is approximately 12 hours. Suppose if the approximate half-life is 12 hours, so what dosing you will be giving? BD dosing. Why? Because it will be eliminated around after 12 hours. Okay, but we see a wide variability there, that is 6 to 33 hours is the variability we see, 6 to 33 hours. Okay, clear? Okay, because of this variability, clozapine levels can differ between the patient even at the similar dose. Okay, coming to the, so remember this, this is asked frequently in exam. Half-life, what is the T half-life? That is 12 hours. You can see in the standard textbook, it's even almost same even in the CTP also. Okay, a reference I am quoting because it will be asked in the exam. Okay, coming to the fifth, drug interaction. Drug interaction. So what I told, that what is the important CYP enzyme you should remember, that is CYP1A. Okay. So first, what is important, that is CYP1A2 inhibitors. Okay. So clozapine metabolism is actually strongly regulated by CYP1A2. Okay. So strong CYP1 inhibition, CYP1A2 inhibition, strong inhibition can increase the clozapine level. Okay. It can increase the clozapine level. And what we need to do? What we need to do? We need to decrease the dose. Okay. What are the example of strong CYP2 inhibitors? One is fluoxamine. Okay. Ciprofloxacin. What is ciprofloxacin? Antibiotic where we give mostly in we give in UTIs. So you should be very careful while when you will be prescribing this uh, antibiotic. And when these drugs are actually given with clozapine, it is very important to know that dose of clozapine should be reduced to one third, of the normal dose. You know, sometimes actually uh, we also use this as a very useful purpose. How? Let me tell you. Sometimes we see that after a certain level, patient is not able to tolerate clozapine. It starts showing the side effect like cyalluria, most of the sedation. Okay, there we are not able to actually increase the dose of clozapine to reach its efficacy. So what happens in that case? We can use fluoxamine as an augmenting agent, fluoxamine or fluoxetine, anything which actually inhibit the CYP1A2. So without actually increasing the clozapine dose, we increase the clozapine level. Okay. By increasing the clozapine level, what we'll be doing? We'll be increasing the efficacy of clozapine, but at the same time, the side effect will not be increasing that much. So it is not always that the inhibitors are bad. Sometimes it also acts in the good way. Okay, understood. So it is not necessary that the sudden increase in clozapine level will always be bad, which can cause toxicity. Sometimes we can use also this in the clinical setting to increase the level of the clozapine when the dose of the clozapine we can't increase because of the burden of that effect. This is clear. One important thing which is again and again asked in the exam: what is the relation of clozapine and smoking? Okay, what is the relation of smoking and clozapine? So what is the relation? Can you tell? What is smoking? What does smoking do? Smoking actually induce CYP1A2 enzyme. So CYP1A2 enzyme it getting induced. What will be doing? It will reducing the clozapine level. By how much it will be? By approximately 30 to 50%, it will be decreasing the clozapine level. So smokers may require higher doses than non-smokers. Smokers requires higher doses than non-smokers to get the same effect. Okay. What happens if the smoking suddenly stop? What happens if the smoking is suddenly stop? This is important. If the smoking suddenly stopped, what happens? CYP1A2 induction falls. Clear? Metal close up. So it will be induction will be for falling. So what will happen? CYP2 induction is falling. So clozapine metabolism will slow down. Okay, slow down. It will increase the clozapine level rapidly. Okay, and which can cause toxicity. Okay, so during extended smoking cessation, clozapine dose may need to be decreased by up to 50%. Okay, whenever there will be we will be stopping the smoking for a significant level, then clozapine dose may be decreased by up to 50% so as to decrease the chances of toxicity. Okay, clear? And it is very important to know that it is not the nicotine. Okay, it's not the nicotine. It's actually the smoke that induces CYP1A2. So write this very clearly. Write this very clearly. It is the smoke. Okay, it is the smoke and not nicotine itself that induces CYP1A2. Why? Because the CYP2 induction occurs by the polycyclic aromatic hydrocarbon in the tobacco. Okay, so the induction which is happening, it is actually occurring by polycyclic aromatic hydrocarbons in smoke. Okay, not by the nicotine. So this is actually important for you to know. So suppose someone is taking nicotine lozenges, will the clozapine level decrease? No, no, not at all. Okay, this is clear. So coming to the what are the available forms? Available forms, can you tell me? It is available in the form of tablets, oral tablets, oral tablets. Dose 12.5 mg, 25 mg, 50 mg, 100, 200 mg. Okay. Sometimes even it is also available in form of oral disintegrating tablet, oral disintegrating tablets of the same strength. Okay. It also comes in form of oral suspension. Okay. Even clozapine long acting is coming, but it's not available in India, and you can go and read about clozapine long acting in Maudsley. Okay. This is homework for you. Clozapine long acting injectable, read from Maudsley. You need to remember, read this. It's a homework for you. And suppose if you don't understand, you can come and write in the comments that you want again a lecture for discussing about the clozapine long acting. We'll be discussing it again. Okay. Coming to the dosing guideline. Okay. Coming to the dosing guideline. So dosing guideline has actually been changed in the new Maudsley. Dosing guideline has actually been changed in the new Maudsley. Earlier, the usual starting dose was 12.5 mg at night, but the new Maudsley says that the dose is, we have to start with a dose of 6.25 mg in the night time. Okay. Now, what is important in the dosing guideline? The important thing is, first, it should be initiated slowly. Why? Because of the side effect. Which side effect? One was orthostatic hypotension, which could cause cardiovascular collapse. Okay. So the what are the reason? If someone asks you what is the reason for slow titration, the first reason important is severe orthostatic hypotension. Clear? Second is, if it is initiated very rapidly, it cause seizure. Okay. Third is sedation, and the fourth is respiratory or cardiovascular collapse. So because of these four reasons, actually, it is initiated slowly. Okay. Coming to the starting dose, I'll be telling you the target dose also, and after the starting dose, the regimen of the OPD regimen, you can go and read from the Maudsley. Okay. How it is initiated on the first day, fifth day, 10th day. I'll be just giving you a blank idea how you should be increasing. But the exact regimen, if you want to see, you can go and read from the Maudsley 15th edition. Okay. So clozapine, the usual starting dose is, the new Maudsley is 6.25 mg at night time. Why night time? Because it could cause hypotension. If the patient is sleeping, there will be no hypotension and the possibility of fall will be less. And as well, it causes sedation. So in the night time, it will cover the sleep also. Okay, clear? Why will be giving at night? Coming to the titration part. Okay, the dose is gradually increased. See, this I have taken from Maudsley only. Gradually increased by 25 mg to 50 mg. Okay, every 2 to 3 days. This is important to remember. Okay, rough idea, because you will not be remembering exact thing in the OPD setting. So what is important? How you will be titrating? It will be titrating like gradually increasing by 25 to 50 mg every 2 to 3 days. This is clear. Okay. After this, what is important? The target dose. Coming to the target dose. Also, one thing you should remember: target, the titration. Titration is not always what I have given here. The titration also depend upon the patient. Why? The patient tolerability may be different. So what may happen? The titration should actually be as per the individual. If the patient is tolerating well, you can titrate at a bit fast rate. If the patient is not tolerating, you need to slow up the titration. Okay. Now, what is the target dose? Okay. So the usual target dose, okay, usual target dose is around 300 to 450 mg per day, and it should be generally reached. It should be generally reached by end of 2 to 4 weeks. Okay. And what is the FDA maximum dose for maximum dose as per the FDA of clozapine? It is 900 mg per day. I'll be telling you 900 mg per day we can give by the as per the FDA. That is not useful. It will just increase the side effect profile. Okay. I'll be telling you with the reasons. Okay. So as per the new Maudsley, okay, you need to remember this. The what is the actually the target dose in different patient group. As per new Maudsley, what is the target dose? Okay, so easy to remember. Female non-smoker. Okay, female non-smoker. Then come male non-smoker. Then female smoker, and then male smoker. I'll also be telling how to remember this. So first, it is for female non-smoker, the dose is target dose is 225 mg. Okay, understood. For male non-smoker, it is 275 mg. For female smoker, it is 300 mg. Okay, and for male smoker, it is 375 mg. Clear? I think this must be clear for you. Okay. Hmm. This one is for actually the white population. White population. Then coming for the Asian population, as per the new Maudsley, as per the Asian population. Okay. So as per the Asian population, what is important here that the female non-smoker for the Asian population, the female non-smoker is having the dose of 175 mg. Okay. Female smoker will be having a dose of 225 mg. Okay. For male smoker, it will be 250 mg. And for male non-smoker, it will be 225 mg again. Okay. This is clear. I hope this is clear. So for white population, the female non-smoker is having a dose of 225 mg. Okay. For me, female smoker, it will be 300 mg. For male non-smoker, it will be for male non-smoker, it will be 275 mg. And for male smoker, it will be 375 mg. Okay, clear? Now coming to the important thing, which is therapeutic dose monitoring. Therapeutic dose monitoring. So therapeutic dose monitoring, why it is important? Because it can cause toxicity at even whenever the dose increases, and it can also induce seizure at a higher doses. So in this case, the therapeutic plasma level for clozapine is at least 350 nanogram nanogram per ml, and most of the patient respond between most patient respond between 350 to 600 nanogram per ml. Okay, clear? And it is seen that levels above 700 is poorly tolerated. 700 nanogram per ml is poorly tolerated. Okay. So the if we practically if we see less than 350, 350 to 600, okay, greater than 700 and greater than 1000. So what is important? Below 350, response is less likely. 350 to 600 nanogram per ml, what it will be? It is a common therapeutic range. Common therapeutic range. Okay. Greater than 700, again, poor tolerability. Why? Side effect. And greater than 1000, what happened? There is high toxicity. High toxicity and seizure risk. Okay. Now coming to what to do when there is missed doses. What to do when there is missed doses. This is very important safety point we should be considered. So if clozapine is interrupted for 48 hours or more, clozapine is stopped or missed for 48 hours. 48 hours means 2 days or more. Then what to do in this case? You have to retitrate the clozapine from the beginning. Retitrate from beginning. That is 6.25 mg. And suppose why this is important. Why this is important? This is necessary to prevent again the same thing. Sudden respiratory arrest. Okay. What other thing I told you? Sudden cardiovascular collapse. What other thing I told you? Orthostatic hypotension. Orthostatic hypotension. Okay. Here. And it is very important to know and note that never restart a previous high clozapine dose after a gap of 48 hours or more. This much is clear. Suppose what happens if the stopped clozapine is dose is missed, but the duration is less than 48 hours. So you should not give 2 times the dose. You can actually start from the previous dose what was being given. Okay, clear? This much is clear. Now coming to the side effect. Side effect. Suppose during the teaching time, if some mistake happens by me, please do let me know in the comment so that we can correct it in the next lecture also. Okay. So what is important in side effect? Clozapine side effect is actually dose dependent, time dependent. Sometimes it become more prominent during titration, and it also fade as tolerance develop. Okay. So we'll be actually taking side effect one by one, and I'll be telling you the mechanism, so it will be very easy for you to recommend. So the first side effect was weight gain and metabolic syndrome. What was the receptor responsible for this? We studied earlier. The receptor responsible was H1 and 5-HT2C receptor blockade. Okay. So what it cause? It will be causing severe weight gain, dyslipidemia. It will be causing insulin resistance, and insulin resistance will in turn cause diabetes mellitus. An important thing you should remember that approximately 50% of the patient taking clozapine experience around 20% or more increase in the total body weight over time. Okay, this is an important thing you could remember that 50% of the patient on clozapine. Okay, what happens? It has been found that there is an increase in 20% or more increase in total body weight over time. It is actually very clinically important because it affects as the patient as well as the compliance. Okay, coming to the second side effect, that is hypersalivation or cyalorrhea. Okay, so what happens because of the clozapine? It actually causes profuse drooling of the saliva, especially at night. So what happens whenever the patient get up? You will see in the clozapine patients that you will get up, then you will be seeing that their pillow is actually soaked because of the hypersalivation. This is also this effect is important. Why? See, clozapine. You know that clozapine is having a paradoxical. Clozapine is actually having strong anticholinergic activity. Okay, so it must ideally be causing dry mouth. So this is actually a paradoxical effect. And what is proposed mechanism for this? That clozapine, what it will cause? It will cause their act on the M4 receptors. Okay, thus it will be stimulating the hypersalivation, and at the same time it will be causing alpha 2 adrenergic antagonism. Okay, so and at the same time it will be causing impaired swallowing reflex. Okay, so because of this there will be hypersalivation. And in the rare cases what we see that severe drooling can cause aspiration pneumonitis, which is actually a common cause of death in case of clozapine patient. Okay, so this profuse drooling of the saliva can lead to aspiration pneumonitis. So we'll be writing about this. Okay, so this is actually a paradox. Why paradox? Because clozapine has strong anticholinergic effects. I'll be making a short video again on the why how clozapine is causing hypersalivation. See, this video is already in detail about clozapine, so I'll be making a separate small video. Okay. So what happened? It is actually a significant side effect, and it is seen in vast majority of patients. Okay. What are the reasons? The reasons are: first one is M4 muscarinic effect. Second one is alpha 2 blockade, and third one is impaired swallowing reflex. You know what? Uh, why this side effect is important? Because sometimes it is a cause of non-compliance. Why? Because drooling of the saliva, it actually becomes socially embarrassing, and also medically important. You know, medically important. See, so if we ask how we will be controlling the hypersalivation, so someone will be saying that we can give the systemic anticholinergic, which will be actually causing the blockade. But do you know what is the problem with giving systemic anticholinergic in case of clozapine? Clozapine is having itself an anticholinergic effect. And you know, one of the rare fatal side effect, but not a rare, which is actually a common fatal side effect of clozapine is constipation, which can lead to paralytic ileus, and it has a mortality very high. So if we will be giving a systemic anticholinergic like glycopyrrolate, okay, which will be so it could further worsen the constipation. So another thing we can try here for the non-pharmacological management. What is the non-pharmacological management which we can do? We can ask the patient to keep a towel while sleeping in the night on the bed. Second thing, we can ask the patient to give a chewing gum to chew. And the third one is we can give eye drop, that is atropine 0.1% eye drop we can give sublingually. Okay, atropine 0.1% eye drop sublingually we can give BD, and it is shown, although it is not FDA approved, but it has shown a good side effect. And if you it has also been given in the book. Okay, now coming to the third most important side effect which I was discussing with you all, that is constipation. So do remember that it is not a minor side effect. Just as I told you, it is not a minor side effect. Minor side effect? No, it is not a minor side effect. It's actually a major side effect. Why? Can be life-threatening. Why? Because why it happens? Because of the strong anticholinergic effects and anti-serotonergic effects, which can lead to severe GI hypomotility and constipation. So what one thing you need to remember, that the risk of constipation, when is the highest risk? The highest risk of constipation is during the first 4 months. Highest risk I'm talking about. Okay, highest risk is during the first 4 months. Okay, but the risk can persist long term. Clear? And suppose if you are not able to recognize it, if not recognizable, it can rapidly progress to. It can rapidly progress to what? Fatal, paralytic, ileus, clear, bowel obstruction, which could lead to bowel necrosis. Clear? So it is actually prophylactic bowel regimens are actually recommended in all the patient of clozapine. And suppose if the patient is having constipation, so it's important that you should give Docusate. It's a treatment you could give Docusate. If you want a separate video on the management of clozapine constipation, do write in the comment, and I will be making a separate video on the management of constipation in the clozapine. Okay, so what an important thing what you should take it from here, that in clozapine patient, okay, the constipation must be actively asked and should be actively treated. So the constipation should be actively asked and actively treated. Clear? Now coming to the fourth important side effect, that is sedation. Sedation is highly common with clozapine and it is occurring about, we already discussed, because of which receptors, just we will be summarizing: H1 receptor, alpha 1 receptor, and M1 receptor blockade. Clear? What is a one important good thing about sedation? That sedation may reduce over time. It may reduce over time. Why? Because tolerance develops. Clear, boss? Clear to everyone? Coming to fifth one, tachycardia. This is important. Tachycardia. See, now it is very important to remember, okay? Benign sinus tachycardia is very common during the early treatment. Very common during the early treatment. How it is caused? It is caused by the vagolytic effects as well as the anticholinergic effects. And this affects actually tachycardia particularly occur during the early titration. Okay. However, one thing you should remember, that tachycardia should not automatically be dismissed as benign, because it can also be a sign of myocarditis. Okay. So whenever tachycardia occurs, you should be actually be very cautious and you should ask about chest pain also. Chest pain and diarrhea, because sometimes the tachycardia can lead to it's an indication of myocarditis. Okay, so it's very important to assess the clinical context when assessing the tachycardia. Okay, now coming to since I just told you about the myocarditis, so we'll be discussing about the myocarditis also. Okay, now the sixth important thing is myocarditis. Myocarditis and cardiomyopathy. So what does CTP say? CTP says that clozapine is associated with the increased risk of myocarditis. However, the incidence of myocarditis is very low. Okay, so if it's asked in the exam, what is the incidence of myocarditis? So as per CTP, the incidence is approximately 2.8. Okay, 2.8 per 1 lakh patient, per 1 lakh patient. Okay, per year. Okay. So as per CTP, the incidence is very low, that is 2.8 per 1 lakh patient per year. Okay. Although the incidence is very low, but can result in that. So the clinician should always consider the clozapine possibility of myocarditis. Okay, whenever the patient is complaining of symptoms like such as unexplained chest pains, or there is some patient is complaining of palpitation or dyspnea or fever, flu-like symptoms, or sudden hypotension is occurring or diarrhea is occurring. Okay, because sometimes we ignore these symptoms, and but whenever a patient is on clozapine, we should not ignore. And unfortunately, it is seen that some of these symptoms are common in individuals who are in the early stages of clozapine treatment. Okay, and very important thing to remember that 80% of clozapine induced myocarditis occur during first 6 weeks of treatment. Okay, and suppose if clear, what is the mortality by mortality due to myocarditis? This is very important. It is around 40%. Mortality is around 40%. Okay. So if the mortality is reaching around 40%, so it is very important to we should actually detect it early, and we should treat it. Suppose if this myocarditis is suspected, so what should be done? The first and most important thing which should be done is clozapine should be discontinued. Clozapine should be discontinued, and you should never re-challenge with clozapine. Never start clozapine again. Okay, clear? And what you should do, what evaluation or test you should be doing? The evaluation and test you should be doing, first one is the ECG, which is very important. Second one is the CK level, creatinine kinase level, and the third one is ESR should be performed. ESR should be performed. What could be the indicating symptoms of myocarditis? We should not be ignored. Indicating symptoms of myocarditis, we should not be ignored. First one is tachycardia, as we discussed. I already told you about it, but I am writing so that you could remember. Palpitation, dyspnea, fever, flu-like symptoms, hypotension, and even sometimes diarrhea. Okay, these symptoms should actually raise concern. Now coming to this was the, I guess, sixth symptom, sixth side effect which is responsible. Now coming to the seventh side effect, which is very important and you should remember, that is agranulocytosis. Agranulocytosis and severe neutropenia. Okay, so clozapine induced agranulocytosis is actually idiosyncratic. First, it is important, idiosyncratic and not dose dependent. Which side effect is dose dependent? Seizure. Okay, not dose dependent. Okay, so what is the risk? Agranulocytosis can be fatal. So the risk of clozapine induced agranulocytosis is around 0.73% during the first year of treatment with clozapine, and it is 0.07% during the second year of treatment. Okay, so this data has been taken from CTP. Do remember this, so no need to worry. It is from a source. Okay, and the risk of agranulocytosis is highest during the first 3 months. Risk of agranulocytosis, clozapine-induced agranulocytosis, is highest during first 3 months of treatment. Okay. However, a significant risk still continue throughout the first year of the treatment. Now coming to the risk of neutropenia. Risk of neutropenia. That was the risk of agranulocytosis and the risk of neutropenia. See, clozapine is associated with neutropenia, and the risk is actually around 2.32%. Okay, 2.32% during the first year of treatment. During the first year of treatment. And the second is 0.69% during the second year of treatment. Risk of neutropenia. Easy to remember. So the risk of agranulocytosis during the first year of treatment was 0.73. Okay. During the second year, only displays the 7 to the second position. That is 0.07%. Okay. Coming to the risk of neutropenia, it is 0.23. It is 2.32% during the first year of treatment, and the risk of neutropenia during the second year of treatment is 0.69%. Now you must be asking, sir, what is the definition of agranulocytosis? So just I forgot to tell you earlier. So the definition of agranulocytosis is ANC less than 500 cells per millimeter cube, okay, or WBC count less than 1000 cells per millimeter cube. Okay. So what are the risk factors for agranulocytosis? This is very important to remember. Risk factors for agranulocytosis. Okay. The first is risk factor is increasing age, and the second one is female. There's an increased chance of agranulocytosis in female. And there's always a need for clozapine monitoring system. So before clozapine, the clinician must register the patient with a clozapine monitoring system. This is because the agranulocytosis can be fatal and requires strict hematological monitoring. Okay. So coming to the clozapine monitoring, So as per APA, what we see that WBC monitoring is no longer required. WBC monitoring is no longer required. In the latest revision, WBC monitoring is no longer required. What is required is only ANC monitoring. Only ANC monitoring is required. This much is clear, my friends. Okay. So what should be the initial ANC requirement to start clozapine? The ANC should be at least 1500 per millimeter cube. This is for the general population. And it should be at least 1000 per millimeter cube in case of benign ethnic neutropenia. And what should be the frequency of ANC monitoring? This is frequently asked in the exam. Frequency of ANC monitoring, it should be weekly for the first 6 months, then every 2 weeks for the second 6 months, and monthly after 12 months of treatment. Very easy to remember. Weekly first 6 months, okay, every 2 weeks for second 6 months, and monthly after 12 months of treatment. Okay. And what is the ANC threshold for neutropenia? Okay, the minimum ANC threshold that is not classified as neutropenia is now 1500 per millimeter cube, but previously it was around 1000 millimeter cube. Okay, what is the duration of ANC monitoring? This is important. Duration of ANC monitoring. So ANC monitoring should continue as long as the patient is receiving clozapine. Okay, continue as long as the patient is receiving clozapine. Okay, and suppose if the clozapine discontinued, then till what time we have to monitor? Then it should be continued for at least 1 month. 1 month after clozapine is discontinued. There are some red flag signs we should actually indicate for immediate ANC monitoring and WBC monitoring, that are any sign of fever or sign of infection should be an immediate indication, should be an immediate indication for WBC count. What could be the example? It could be pharyngitis or fever or any sense of infection. Okay, and this is actually important during the first 18 weeks of treatment. Okay, now when to interrupt or discontinue clozapine? This is important. When to interrupt or discontinue clozapine. Okay, so clozapine should be stopped. Okay, if ANC falls below 1000 per millimeter cube. Okay, now what about the re-challenge? Okay, now re-challenge with clozapine, it's no longer is decided by the WBC count. Okay, no longer decided by WBC count. This is clear, and this is based only on ANC. Based only on ANC. Okay, and re-challenge is allowed only after recovering from the moderate neutropenia, which is between 500 to 9099, that is 999 per millimeter cube. Okay, re-challenge is allowed only after recovery from moderate neutropenia. Means it should be allowed only after greater than 1000 per millimeter cube of absolute neutrophil count. What is moderate neutropenia? It is 500 to 999 per millimeter cube. Okay. Suppose the ANC falls below 500 per millimeter cube. This is known as severe neutropenia. Severe neutropenia. Okay. If once a patient develops severe neutropenia, clozapine should never be started again or re-challenged. Okay, this is clear. Now coming to the agranulocytosis. Okay, agranulocytosis and re-exposure. So patient who develop agranulocytosis should not receive clozapine again. Okay, so patient who develop agranulocytosis should never receive clozapine again. Clear? Clear? Now, what is the WBC based caution? Okay. Now, although we remember that although WBC count below 3500 is not a proven risk factor, but clozapine should be cautiously given in such patient. Why? Because low WBC count may be an early identification of the agranulocytosis difficulty. Okay. See, why we should not, the patient who are developing agranulocytosis should receive clozapine again, because it has been shown that clozapine re-exposure after hematological recovery, okay, showed that all such patients developed agranulocytosis again, okay, and what it was seen that they developed agranulocytosis even at a lower dose level than earlier. Clear? What is the discontinuation criteria? discontinuation criteria. The discontinuation criteria is, first is, if the total leukocyte count, that is WBC, falls below 3000 cells per millimeter cube, okay, or the granulocyte count falls below 1500 cells per millimeter cube. Now, this is another very important thing we are going to discuss, that is other hematological changes. Okay, the clozapine is a very big drug. I know now it will be becoming tiring for you, but okay, you can watch this lecture in parts. Divide it in the first half studying about the pharmacokinetic and pharmacodynamics. Then in the second half, you can watch about the side effects and how to manage them. Okay. So other hematological changes which is seen is leukocytosis, eosinophilia. See, eosinophilia is very important. It's seen around 1% of the patient. Okay. Even leukopenia is seen. Neutropenia we already studied. Decreased WBCs and we studied, and rarely it can cause thrombocytopenia. Okay, and also decreased WBC count as we studied earlier. This much is clear. Now coming to the eosinophilia management. This is sometime asked in the exam. What to do if eosinophilia is there? Eosinophilia management. Suppose if the eosinophil count rises above greater than 4000 per millimeter cube, then clozapine should be discontinued. Okay, and it should be restarted again only when the eosinophil count falls below 3000. Restarted only below 3000 cells per millimeter cube. Okay, so because of this, clozapine requires the strict hematological monitoring. Okay, and because of the, and you know what, a very important thing which actually prevents the clinician from starting clozapine is actually agranulocytosis, despite being highly effective. Okay, coming to the next important side effect which you should remember is seizure. Seizure is a side effect which is actually dose dependent, and what is important is to know the incidence, that is 5-10% of the patient treated with clozapine develop seizure. Okay, 5 to 10% of the clozapine patient will develop seizure, and the risk is clearly related to dose. Second important thing is it is dose dependent. So if it is dose dependent, when does the risk increases? It increases at a dose of greater than increase dose of 600 mg per day. Okay. Also the rapid acceleration, that is increased titration may lead during the first week. Okay. During the first week, okay, it increases the likelihood of seizure. Okay. Also, if there is a pre-existing seizure disorder, okay, or head trauma, it put the patient at a again greater risk. Okay, so a number of strategies may be effective for managing the risk of seizure. First, that monitoring the clozapine plasma concentration. Okay, see in India at many places it is not available, so it's very important to monitor the side effects very carefully and try to keep the dose of clozapine below 600 mg, because above 600 mg it has been shown that it's not much effective, but it increases the risk of seizure. Okay, so, and one more important thing you should remember, that the occurrence of the seizure in patient treated with clozapine should not be viewed as a clear reason to stop clozapine. So what should we do if suppose a seizure occurs? Suppose if the patient develops seizure. Okay. First one is decrease the dose and adding an anticonvulsant. Adding an anticonvulsant is usually sufficient to prevent seizure. Okay. So what are the drugs which have been shown to prove efficacy in treating clozapine-induced seizure? Sodium valproate, topiramate, and gabapentin. Gabapentin. See, carbamazepine should not be prescribed. Why? Because it can also cause neutropenia or granulocytopenia. So the effect of the carbamazepine and the clozapine neutropenia effect will come together, and it could cause severe neutropenia, and it could lead to stoppage of clozapine. Okay, this is clear about the side effect. Now coming to the black box warning. Coming to the black box warning. What are the black box warning? First black box warning already we studied. Agranulocytosis and severe neutropenia. Second is seizure, which is mainly above dose of 600 mg per day and the plasma level of greater than 1000 nanogram per ml. Third one is fatal myocarditis, incidence rate up to 40%. Okay, and especially during the first six weeks it happened. Okay, fourth one is orthostatic hypotension, bradycardia, and syncope, which can lead to cardiovascular collapse. Okay, and the fifth, which is actually common to all the antipsychotics, that is increase mortality in elderly patient with dementia related psychosis. Okay, this is clear. Okay, so coming to the special population. Now this was for clozapine. Coming to the special population, that is in pregnancy and breastfeeding. See, important here is that clozapine crosses the placenta. Although animal models do not show any kind of teratogenicity, but human data are limited. So it is very important that if the neonates are exposed during the third trimester, are at severe risk for EPS and the withdrawal symptoms. Okay. Suppose neonates are exposed in third trimester, so they are at risk for EPS or withdrawal symptoms. Or withdrawal symptoms. This is clear. So what happens? What are the withdrawal symptoms which can be seen in the neonate? The withdrawal symptoms which can be seen in the neonate are abnormal muscle tone. It can the second variable will be agitation, respiratory distress, and feeding difficulty. Feeding difficulty. One important thing is that clozapine is also excreted in breast milk. Clozapine is also excreted in breast milk. So what is important that in case of clozapine, when the mother, what should we recommend to the mother? We should recommend to the mother that strictly they should give bottle feed instead of the breast feeding. Okay, this much is clear. Breast milk. So what we should be saying to the mother that they should be giving bottle feed if they are on clozapine. Okay. Also, as per the FDA, clozapine comes in pregnancy category B. Category B. So this is important. Clear? Coming to the next important population, that is children and adolescent. In children and adolescent, still the efficacy has not been established. However, we can give it in early onset treatment resistant schizophrenia. Okay, at early onset treatment resistant schizophrenia. But what we can do is that we can actually do a substantial closer monitoring, careful clinical monitoring, and careful hematological monitoring, as they are more prone to the side effects. Coming to the elderly patients, elderly patient, and in case of organ impairment. Organ impairment. Okay. So clozapine should be used with extreme caution. Extreme caution in patients who are having cardiac impairment. Why? You know that it has an effect on cardiac, myocarditis, tachycardia, hepatic impairment. Why? Because extensively metabolized by the liver. Okay. And renal impairment because it is getting excreted by renal too. Okay. Why the elderly patient should require extra caution? Why? Can anyone tell? See, why? Because the elderly patient are more sensitive to the anticholinergic delirium. Elderly patients are sensitive to anticholinergic delirium. This is clear. Second is orthostatic hypotension, which may increase the propensity of the fall, and sedation, again, which increases the propensity of fall. Okay, and this will be actually increased by clozapine. So what we can do in the elderly patient? In the elderly patient, what we can do in case of clozapine? Much slower titration. Okay, low starting dose and more careful monitoring. More careful monitoring. So this is all about the clozapine. Okay. So if you can summarize the clozapine, it's actually a second generation antipsychotic with mainly as per the NBN classification. If we see what it is important, it is a serotonin. Okay, it is a serotonin dopamine antagonist. Okay, dopamine serotonin noradrenergic receptor antagonist as per NBA classification. What are its unique mechanism? That is weak D2 blockade, where it occupies only 40 to 50% of the striatal D2 receptors, fast D2 dissociation. It has an antagonism at 5-HT2A receptor, which is actually responsible for the antipsychotic effect as well as for the low EPS propensity, high D4 receptor affinity, as well as antagonist action on the H1 alpha 1 and alpha 2, which is responsible for the sedation, and on the 5-HT2C. So 5-HT2C will be actually responsible for the cognitive improvement as well as for the symptoms of treatment of the negative and the cognitive symptoms, but it comes at a cost because 5-HT2C and H1 is responsible for weight gain, dyslipidemia, insulin resistance, as well as diabetes mellitus. It has also partial agonism at 5-HT1A, where it can cause anxiolytic effect. It has a metabolite that is NDMC, where it acts as an M1 agonism, which actually responsible for NMDA modulation in the hippocampus, which is actually responsible for the cognitive and the negative symptom improvement benefit in case of schizophrenia. There are multiple off-label use which you can do. Its half-life, which is important to remember, that is around 12 hours as per the CTP, and it's the minimum effective dose is around 6.25, and the minimum therapeutic level plasma level is around say 50 nanogram per ml. The major adverse effect which you should remember on fingertips, that is severe weight gain and metabolic syndrome, cialorrhea, constipation, sedation, tachycardia, agranulocytosis, seizures, myocarditis, cardiomyopathy, orthostatic hypotension, bradycardia, and syncope. On the black box warning, there are a total 5 which you should remember, that is severe neutropenia and agranulocytosis, seizure, myocarditis and cardiomyopathy, orthostatic hypotension, bradycardia and syncope, and increased mortality in elderly patients with dementia-related psychosis. One more important thing is at the end, which I'll be telling, this is actually very important, is polydipsia hyponatremia syndrome. Okay, one important thing is polydipsia hyponatremia syndrome. This I forgot to tell you. See, it has been suggested that clozapine may have advantages over the other antipsychotic agent in patients who tend to intoxicate themselves with water. Okay. And this syndrome, actually polydipsia hyponatremia syndrome, can result in seizure. So it has been seen that clozapine is more effective than other antipsychotic. So this is clear about clozapine. So in the next lecture, we will be discussing about aripiprazole in detail. Till that time, one important thing to know that you should go and read from the Maudsley, the how is the titration about the clozapine as well as long acting formulation of the clozapine. Thank you.